Extract 1. Questions 1 to 12.
You hear a physiotherapist talking to a patient called Greg Freeman, who's been referred to her by a sports medicine clinic. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
OK, Greg, so I have your notes from the sports medicine clinic, and it looks as if you've had quite a few problems in recent years.
Yeah.
Would you like to talk me through them?
Okay, well, the first time I got hurt was 2 years ago. I took a fall while I was rollerblading and I hurt my right wrist here on the side. So I didn't do anything right away, but next day I went and saw the doctor and they gave me an x-ray, but they said they couldn't see anything wrong and they just gave me some exercises to do.
Right.
Then a year ago, I hurt my right shoulder here when I came off my snowboard and hurt myself. That's never really gotten better.
And I understand you've had about 10 visits to the clinic over the last 2 years. So that's your right wrist and shoulder?
Mm-hmm. And other joints, too.
Tell me about this pain in your shoulder. Is there anything that makes it feel worse?
Well, I like to do a lot of exercise, but that definitely makes it worse. Like if I do a set of pull-ups in the gym or rowing, or if I'm using the free weights, pretty well any sort of exercise I do, I find the pain's pretty bad.
Right.
And it's not just when I'm in the gym, it's constant, all through the day. There's no fluctuation, so I never get a break from it. It's really got me down, and no one seems to know what to do about it. They've diagnosed various different things, and I have to lie on my left side at night, or the pain disturbs my sleep, so that's not easy.
So, apart from that, are you generally in good health?
I suppose so. But what I've noticed is that my right wrist sometimes feels cold,
OK.
and there's no reason I can see for that. And the same for my left knee. It suddenly goes cold. It's very strange. When I told the doctor about that, he checked to see if the blood flow was okay, and it was.
Right.
And he asked if I felt any numbness there, but I don't.
OK. That's quite strange. And have you had any medical problems in the past?
Well, the only thing really is, I used to have really bad acne. It started when I was about 13, and I got it on my face, and then it spread to my back, and nothing I did seemed to have any effect on it. Like, first, my mom went to the pharmacy, and she got this stuff I rubbed on. I can't remember the name. It was something peroxide.
Benzoyl peroxide?
Yeah, that's it. But that didn't do any good, so my mom took me to the doctor, and he gave me antibiotics, and they didn't do much either. Then I read this article that said it can be caused by your diet, and you should cut out dairy products. So I did that for a bit, but it just got worse. And it got so I didn't want to go out or anything. So then my doctor referred me to the hospital, and I saw a dermatologist. She was really nice, and she prescribed me some stuff that was much stronger, and that did have an effect for a bit, but I got really dry lips, and they started cracking and bleeding.
OK.
And another side effect, well, she said she wasn't sure it was due to the medication, but I think it was. Every so often, I started getting this awful depression. So, in the end, I stopped taking anything, and it seems to have sorted itself out.
Yes, your skin looks fine now. Right, so let's have a look at this shoulder of yours. Can you take...
Extract 2. Questions 13 to 24. You hear an anaesthetist talking to a patient called Mary Wilcox prior to an operation. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mrs. Wilcox, you tell me you've had high blood pressure. So, are you taking any medications for that?
Yes, a blue one and a white one.
Mm-hmm. And do you know the names of the tablets?
Yes, so one's thiazide
Okay,
and the other one's lisinopril.
perfect. Thank you, that's very helpful. And have you had them this morning?
Yes, that's what the nurse told me at the pre-assessment, yes. So is that all right? Just with some water? I usually have them before breakfast, but she said no food at all this morning.
Excellent. And apart from the high blood pressure, do you have any other medical problems at all?
Yes, I take some blood-thinning drugs because I had a small heart attack a bit ago, so I'm taking aspirin. And at the pre-assessment, they said to keep on with them, so I had one this morning like I usually do. They told me to stop the other one. I can't remember the name.
Warfarin?
No, it begins with C. Clopidogrel. They told me to stop it a week before the operation, 7 days.
Fantastic.
So I stopped last Tuesday.
Great. Now, tell me a bit more about this heart attack. How long ago was that?
2 years ago, my GP picked up on it.
Did that all go...
Yes, pretty good.
And why did you go to your GP? Were you having chest pains?
They weren't chest pains. They were, I was just getting a bit breathless, and it was difficult for me to tell what was going on, but Dr. Scott picked up on it when I went to see him, and he sent me to the cardiology team.
Right. Did they say you'd had a heart attack?
Yes, they told me I'd had a small one, and so I had some stents put in, a couple of them.
And since they were done...
Yes, I've been better. You know, I don't feel so tired all the time.
OK. And what can you do in terms of exercising?
Well, I can do anything. Anything, really.
Tell me what you can do.
Well, we have stairs at home, and we don't have a loo on the ground floor. It's on the first floor. So I'm up and down a few times a day.
And walking on the flat's fine?
Yes, that's okay.
Any problems with your ankles swelling?
Well, this one, it swells up if I've been standing. I had my veins done, my varicose veins, but the other one's all right. I sprained it quite badly last year, but it's fine now.
Right. Can I just ask you a few other questions about your heart?
Sure.
Have you ever had any palpitations at all, when your heart goes bum bum bum?
No.
You've never experienced any of those?
Well, no, not really. I mean, if I run, my heart beats a bit faster, but that's normal, isn't it?
Sure. Anything else? Any digestive problems?
No. Oh, well, if I have a heavy meal late at night, like if I have a pastry or something, I sometimes wake up in the night feeling a bit like heartburn. But if I take an antacid, it's fine.
Right.
So, in general, you sound to be in pretty good shape. Now, in a minute, I'll tell you about exactly what type of anaesthesia we'll be using. But first of all, is there anything you'd like to ask me? Do you have any concerns about anything?
Well, I suppose the main thing is after the operation, when I wake up. Will I be in a lot of pain when I come round?
No, you'll be given morphine during the procedure, and that will still be working when you wake up. And then, when that wears off, you'll be given something else. There'll be someone keeping an eye on you.
OK. The other thing is, I've heard that if you have crowns in your mouth, they can get damaged if they put in an air tube.
Well, it's unlikely, but we'll take special care. So, which teeth are we talking about?
These two.
OK, the two central incisors. And do you have any other teeth with crowns or implants?
No.
OK. So, what we have planned for you is to take...
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Professor Lynn Fritschke is a cancer epidemiologist at Curtin University in Perth and chaired the subcommittee at the International Agency for Research on Cancer, which concluded just how carcinogenic Roundup and his stablemates are.
Now read the question.
Where does that leave us? I mean, is the IARC going to change its mind now?
I don't think there's enough evidence to change the mind yet. I mean, a possible carcinogen is still the case. There is very strong mechanistic evidence that glyphosate can damage cells and damage DNA in animals and possibly in humans as well. And so there is, some evidence that it may be carcinogenic. So I think just having that other one big study doesn't necessarily negate the whole decision.
So where does that leave us with glyphosate for casual use or occupational use? Should it be banned?
I think that might be going a little bit far at the moment with the evidence we have. My personal opinion is that we should minimise it as much as possible, and wherever possible use things that are less toxic or less potentially toxic.
Question 26.
Dr. Diana Adams, a medical oncologist at MacArthur Cancer Therapy Centre and the co-founder of Avexia Care.
Now read the question.
In all cancer types, there is a benefit to exercise. We now know that exercise can actually mitigate some of the side effects of therapy and can actually improve the quality of life for those patients both during and after therapy. In addition, it is possible for some cancers it may actually improve their chances of the cancer not returning. So we know that exercise can actually improve the patient's fatigue through therapy. It's likely to actually improve the chance of them completing their therapy. So the medicines we give to treat cancer can increase the chance of side effects and fatigue, and exercise can ameliorate these side effects. We know that it is safe, it's been proven in clinical trials, with actually quite significant volumes and intensities of exercise. A classic example would be prostate cancer, where we suppress testosterone. And we know that testosterone is important for muscle mass. So by using exercise, we can counteract some of the effects of that muscle loss through a tailored program.
Question 26.
Dr. Jules Montague is a neurologist from Dublin and author of Lost and Found: Memory, Identity and Who We Become When We're No Longer Ourselves.
Now read the question.
Sure. So you would think that your most emotional memories would be the most accurate, but it transpires that's not the case. If you look at things like the Challenger disaster or 9/11 or Lockerbie, for example, plenty of studies have been done in some of these scenarios where people will impart memories, for example, as you said, in 9/11. And there was a study that looked at downtown participants, so people who were really close to what happened and some who were further away. And those who were involved and closer to the action of what happened that day actually had lots of memories to impart, and they were very vivid, but not necessarily more accurate. So they were able to fill in lots of information, but it wasn't necessarily accurate. We think that's because the way our memory works depends on how much emotion is in a situation. So if you're personally remembering something very emotional right now, the hippocampus, of course, is kicking in. That does memory. But so is the amygdala, which is all about emotional memories. And that means your memories certainly are more vivid, but it doesn't mean that they're more accurate. And again, it's not that you're lying in any way. It's that the circuitry in your brain, for evolutionary purposes, has decided to kick in a slightly different way.
Question 28. You hear.
Dr. Charlene Wong, a paediatrician and health policy researcher at Duke University in Durham, North Carolina.
Now read the question.
And the study is to collect deep health data in a cohort of at least 10,000 people in the US in an effort to map human health and health transitions.
And they know that they're being mapped?
They do. They are agreeing to be part of the study. Many of them have joined the study because they're actually very excited and altruistic in wanting to help map human health.
So this is what technically would be called a cohort study.
That's correct. It's a longitudinal cohort study.
So you're gathering a group of people together and you're following them through to see what happens to them. And why is Google involved? Are they picking up data from their behaviour online to assist you, or are they just using Google to recruit?
Sort of all of the above, I would say. We are collecting a broad range of different types of data, from imaging studies to blood tests and urine tests and even tests on the stool to look at all the different molecular markers that are available currently. We are also eventually going to be looking at other types of data, including data from people's medical records, data from what they are doing online. This study is still evolving to determine what all the data points that we might be collecting will end up being.
Question 29. You hear.
Dr. Claire Ashton-James is a senior lecturer at the University of Sydney and works at the Pain Management and Research Institute at Sydney's Royal North Shore Hospital.
Now read the question.
Claire Ashton-James.
The important thing to realise about pain is that it's a subjective experience based on three main components. There's somatic input, so feelings of aversive sensations. There's an evaluation of those sensations, so how harmful or threatening are these sensations, which is subjective. And then there's also the emotional component, so how distressed am I in response to these aversive sensations. And the social context you're in when you experience pain directly influences your evaluation of how harmful the sensation is, how potentially threatening it is to be in pain, to be injured in that situation, and very closely related to that is the amount of distress you feel in response to that aversive sensation.
So what are the implications for how we can better manage people who are in pain?
My research focuses on healthcare professionals and their role in patients' pain experience.
Question 30. You hear us.
A Health Minute with Dr. Norman Swan.
Now read the question.
I assume that given the choice, you'd rather age with your marbles intact, and there is evidence that lifestyle matters. But what about specifics like physical activity and diet? Particularly the Mediterranean diet, which is typified by a low proportion of land animal protein, lots of plant-based foods, olive oil as a source of fat, and a little wine. Two recent studies of people in their mid to late 70s help a little. One study followed people in New York for over 5 years, looking at the incidence of Alzheimer's disease, and found that exercise, particularly more vigorous exercise, reduced the risk of Alzheimer's, as did closely adhering to a Mediterranean dietary pattern. About 1 in 5 people with the lowest level of exercise and diet adherence developed Alzheimer's, compared to about 1 in 8 who were goody two-shoes, and that was after allowing for other differences between the groups. The second study in France looked at decline in thinking ability in the Mediterranean diet and found a weaker link and no effect on the risk of dementia. It may be that in France the average person eats more of a Mediterranean diet than Americans to start with, making differences hard to find.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best, according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You will hear an interview with a sports injury specialist called Toby Walsh on the subject of hamstring injuries. You now have 90 seconds to read questions 31 to 36.
My guest today is a sports injury specialist called Toby Walsh. We're going to be talking about hamstring injuries. Toby, hamstring injuries are something sports people at all levels of ability fear getting. Why is this?
Well, you're right. Hamstrings are the most significant injury in a number of team sports, including football and rugby, but any sports person could be affected. I think, looking at the statistics, hamstring injuries account for the largest number of lost playing hours amongst professional footballers, even though the average injury only takes about 3 weeks to heal. More worrying for the individual is that once they've had such an injury, the chance of sustaining another one in the same season is as high as 20%, so it can become the thorn in the player's side. That, I think, accounts for the reputation the injury has.
So is this an injury that can affect any of us at any time?
Well, the hamstrings are a group of muscles in the thigh that allow us to bend our legs and knees effectively. Now, some ethnic groups are more predisposed to these injuries than others, and everyone's chance of tearing the muscle increases with age. But apart from that, they're generally the result of short bursts of movement, like sprinting or suddenly changing direction, and they happen more in certain sports because these are just the sort of movements that players are making. They happen most often at the end of what we call the swing phase of running, just before the outstretched leg hits the ground and the muscles contract to bend the knee.
But I'm sure there are ways to prevent these injuries.
Well, looking after the muscles themselves obviously helps here. You can do various exercises that actually strengthen the hamstrings and so make them less prone to injury. And of course, warming up before exercise is crucial in avoiding all sorts of muscle strains, and sports people know that. But that isn't the whole story. One interesting finding is that a lot of people who develop hamstring injuries have coexisting back problems, and there would seem to be a correlation. By loosening up the lower back, you also help the nerves that control the hamstring. Flexibility there allows the muscles to function as they should, and there are exercises people can do to help that.
And is the risk of hamstring injury something that should be taken into account in training programmes?
Well, yes. Intensive training, of the sort you do for team sports like football, can put quite a heavy workload on the gluteal muscles, which can lead to a tightening around the hips, creating knots known as trigger points. These, in turn, can cause referred pain in the hamstring, reducing flexibility and increasing the risk of straining or tearing it. I mean, basic stretching exercises can help here, but also we know that muscles are more likely to strain if they're fatigued. Often, during a period of intensive training, you get cumulative fatigue. This can creep up on an athlete, on their muscular system over a number of weeks as the training intensifies.
And if an athlete does pull a hamstring, how can the sports injury specialist help?
Well, they'll feel the pain, maybe even feel a pop, and they won't be able to continue because the muscle will go into cramp and spasm. There are 3 degrees of severity, and the treatment will vary according to that. Fortunately, as a sports injury specialist, you're often present when the injury occurs, or you can see it on video, so you don't have to rely on a verbal account of symptoms to assess the severity. Initially, you want to stop any swelling as soon as possible. That's your priority. You're going to apply compression bandages and possibly ice. Although there's some debate about that these days, it does ease the discomfort. And you'll certainly elevate the leg and make sure the patient rests up.
And how long will the athlete be out of action?
Well, as I say, that's going to depend on the severity of the injury. They'll have to rest up for 72 hours, whatever happens, to avoid causing further damage. And things like heat and massage can be just as damaging as movement itself. A grade 3 injury can take months to heal and can be career-threatening for top athletes. What's more, lack of use can lead to the development of scar tissue and muscle shrinkage. In other words, the muscles won't return to their former state, even if the tear or strain itself heals. So part of my job is to ensure that doesn't happen by getting the muscles working again in the right way as soon as possible.
Extract 2, questions 37 to 42. You hear an interview with Dr. Craig Harrisberg talking about avoidant personality disorder. You now have 90 seconds to read questions 37 to 42.
My name is Dr. Craig Harrisberg, and I'm a mental health professional specializing in psychiatric well-being. My topic today is personality disorders. People with avoidant personality disorder, or APD, have a lifelong pattern of extreme shyness. They also feel inadequate and are hypersensitive to rejection. APD can cause psychiatric symptoms that create serious problems with relationships and work. If you have APD, you might have difficulty interacting in social and work settings. This is because you may fear any of the following: rejection, disapproval, embarrassment, criticism, getting to know new people, intimate relationships, and ridicule. You may also have trouble believing that people like you. When you're sensitive to rejection and criticism, you may misinterpret neutral comments or actions as negative ones. Researchers today don't know what causes avoidant personality disorder, though there are many theories, however, about possible causes. Most professionals subscribe to a biopsychosocial model of causation. That is, the causes are likely due to biological and genetic factors, social factors, such as how a person interacts in their early development with their family and friends and other children, and psychological factors, the individual's personality and temperament, shaped by their environment and learned coping skills to deal with stress. This suggests that no single factor is responsible. Rather, it is the complex and likely intertwined nature of all three factors that are important. If a person has this personality disorder, research suggests that there is a slightly increased risk for this disorder to be passed down to their children. There is no way to know who will develop APD. People who have the disorder are typically very shy as children. However, not every child who is shy goes on to develop the disorder. Likewise, not every adult who is shy has the disorder. If you have APD, your shyness most likely grew as you got older. It may have gotten to the point that you began avoiding other people and certain situations. Your doctor may refer you to a mental health professional who will ask you questions to determine if you have APD. To be diagnosed with APD, your symptoms must begin no later than early adulthood. You must also show at least 4 of the following characteristics. You avoid work activities that involve contact with others. This is due to fear of criticism, disapproval, or rejection. You're unwilling to get involved with other people unless you're sure they will like you. You hold back in relationships because you're afraid you'll be ridiculed or humiliated. The fear of being criticized or rejected in social situations dominates your thoughts. You hold back or completely avoid social situations because you feel inadequate. You think you're inferior to others, unappealing, and inept. You're unlikely to take part in new activities or to take personal risks because you're afraid of embarrassment. Psychotherapy is the most effective treatment for APD. Your therapist may use psychodynamic psychotherapy or cognitive behavioral therapy. The goal of therapy is to help you identify your unconscious beliefs about yourself and how others see you. It also aims to help you function better socially and at work. Psychodynamic psychotherapy. Psychodynamic therapy is a form of talk therapy. It helps you become aware of your unconscious thoughts. It can help you understand how past experiences influence your current behavior. This allows you to examine and resolve past emotional pains and conflicts. Then you can move forward with a healthier outlook about yourself and how others see you. Psychodynamic psychotherapy produces lasting results with benefits that continue after treatment. Cognitive behavioral therapy. Cognitive behavioral therapy, or CBT, is another form of talk therapy. In CBT, a therapist helps you recognize and replace unhealthy beliefs and thought processes. Your therapist will encourage you to examine and test your thoughts and beliefs to see if they have a factual basis. They'll also help you develop alternative, healthier thoughts. Medication. The FDA hasn't approved any medications to treat personality disorders. However, your doctor may prescribe antidepressant medications if you have co-occurring depression or anxiety. People who don't receive treatment for APD may isolate themselves. As a result, they may develop an additional psychiatric disorder, such as depression, agoraphobia, substance abuse problems. Treatment doesn't change your personality. You'll most likely always be shy and have some difficulty with social and work interactions. But treatment can improve your symptoms and help you develop the ability to relate to others.
That is the end of Part C. You now have 2 minutes to check your